Hello, everybody. Welcome to the next episode of DG4Care podcast. In the first two episodes, we've been speaking about the introduction of the whole project and also about its finances. And now we will continue with explaining and describing four of the pilots that we are focusing on. And today we will be focusing on pilot 3, digital healthcare for post-clinical rehabilitation. And I'm pleased that three of the person who were supposed to be here are really here. The first one is Mira Ganova. Mira, welcome.
Welcome. Thank you for the invitation.
Thank you so much. The second one is Ákos Tiboldi.
Hello, it's nice to be here.
And the third one, and it's the person who was already mentioned by Petr Pažitný. If you remember, Petr Vajer. Petr, welcome as well.
Thanks. I'm happy to be here with you.
Thank you so much. And we'll start with the introduction of Mira, of course, because I want to do that. And of course, you're a lady, so it's my honor to let you speak the first.
Thank you very much. So I'm Mira Ganova, and I'm the CEO of Digital Health and Innovation Cluster Bulgaria. We are part of the consortium of our project Digi4Care. Our organization is focused on supporting the digital health transformation in Bulgaria and, of course, abroad by creating an domain expert community with different type of experts, healthcare companies, IT companies, partners, and individuals who can effectively and efficiently support with their domain expertise, their knowledge and know-how, the digital health transformation, as I already mentioned, in Bulgaria. And of course, we are working with other countries and on other projects as well.
Thank you so much. One small comment. Mira and the second speaker, Ákos Tiboldi, are two of the person who will be in two of our podcasts. So Ákos, once again, the floor is yours.
Thank you very much. My name is Ákos Tiboldi. I'm a physician. I'm a critical care physician and an anesthesiologist. And I'm also a senior researcher of the Ludwig Boltzmann Institute. This is one of the institutes, Digital Health and Patient Safety of the Ludwig Boltzmann Association, which is a huge network in Austria having different institutes. So our institute is participating in this project. And one of my most important research areas are post-intensive care, rehabilitation, and this is a great opportunity to use digital devices in rehabilitation now. So
thank you so much.
That's
Ákos.
my role.
Thank you. Petr, what about you? What is your background?
Yeah, my background is that I am a general practitioner originally, and I also run a practice quite close to Budapest. And at the same time, I work for the family medicine department at the Semmelweis University. And why I'm sitting here today is that I work for the National Cardiovascular Center. There's a department responsible for screening and prevention, etc. And besides these kind of activities, we are responsible for most of the international projects which are run by the institute.
Thank you so much, Petr. And let's stick with you. Can you please introduce the topic? Basically, we are speaking about the digital healthcare in post-clinical rehabilitation for CVD and diabetes patients. First of all, what is CVD?
Okay, CVD it means cardiovascular diseases. And the original idea was that what we see in Hungary is that when someone has an acute coronary syndrome, myocardial infarction, maybe it's better understood by non-doctors. We save them very well. We have good results, just like anywhere in Europe. But when we look at the 1-year mortality rate, then it's very, very bad. We have bad results. It means that we have serious
problems. So the
problem.
post-acute healthcare is the problem, not the first acute healthcare that we are providing to the patients, but the treatment that the patients are getting afterwards.
Exactly. So the patient management or rehabilitation, as you wish. And so that's why there was the idea, maybe if we provide them a better management using devices, wearable devices, which then provide us different data And this way, maybe we can have a better look at their health situation. Plus, through a kind of messages or whatever, we can force them to don't forget to take your pills and etc. So it could be a two-ways communication between the health care center and the patient. So that was the original idea, and then in this project, it was maybe the most difficult part to find a common ground, how to put different ideas together, so we can show by the end that if you use different devices, it's good for the patient and it's good for the system.
The crucial question maybe is how do we differentiate the good devices and beneficial devices and the devices that are reliable from the other devices? Because when we are speaking about the devices, we are probably not speaking about the device that you get from Wish for €5 or for €7, including delivery. So how do we find out, and what's the procedure in order to identify which devices should be idle for these purposes?
So we did at the beginning a mapping. It was one of the deliverables of the project that we just focused on different digital devices what you can find on the market. It is not medical grade. These are not medical grade devices. You can buy it by yourself. But we mapped all the devices. We checked what kind of measurements do they do, what is the quality of the measurements, what is written about it, what are the white papers about it. We contacted the different companies. But it was actually very limited because we are in a European Union project, and we wanted to take devices which does not sell our data outside of the European Union. We were not allowed to do that. So we actually were stuck in companies who has the servers, or at least they say that they have the servers within the European Union, and it's not too much. And then among these companies, we just checked the value of the devices, how much money we want to spend, and we narrowed it down to the 1, 2, 3, 4 different one what we actually choose at the end of the day. So it was not a very high sophisticated research-based quality checking workflow. It was very pragmatic, because otherwise we cannot do a European Union project.
Understood.
And also it's based on our purpose for feasibility study, as we cannot do a clinical study in this project because we need wider cohorts and more precise protocols. Of course, we have a lot of clinical insight and clinical protocols, but in fact, we wanted to evaluate the adoption of those technology, the usability of those technology in both patient and healthcare professionals, and prove if the quality of life of patient is improving due to this continuous home monitoring that we are providing to those patients. So we looked for devices that could be easily bought, that could be easily wear, and to be, easily used at home.
We also did in our country, so in Austria, we did a focus group research. In a focus group, we asked patients and healthcare professionals what do they think about a good device, what kind of device could they imagine. We also met a patient board. It was actually a lecture held for dedicated board who is representing patients, and we just told them what we want to do, and they asked very critical questions about the variable, the variables, how comfort, how to wear it, and how how will it be in a normal life. So we could narrow down the options what we had based on different impulses.
To be honest, we're covering a lot of data with these devices. They're easy to wear, of course, but we are giving to patients bracelets. We are giving them smart scale, very, very nice one with a lot of data that can be gathered from it, and blood pressure monitor with Bluetooth. So it's a medical grade device, the Omron, the blood pressure.
The one, yeah.
So they're accurate, but they're easy to wear, and they do not disrupt the comfort of the patient.
What was the response of the patients who were or are using those devices? What were maybe the obstacles that they were facing or the challenges that they were facing?
The acceptance of the idea is very high. So if you go to a patient and you tell them you get some digital devices that I want to monitor you, I think it's a message, you are important. And that was the most important message what we actually want to tell our patient. You are important for us. You are so important that we even want to monitor you between the appointments. You show up in our office. And I think that's why the acceptance was very high, even if it is actually a burden for them to install the scale at home because they have to connect it to the home Wi-Fi network and they have to use the bracelet or the watch
to synchronize the bracelet
sometimes
regularly.
with the
But it's probably user friendly.
it's well,
Sort
it's
of?
not,
It
it's-
depends. It depends. In a country as Austria, with a little bit higher digital literacy, it is easier. In environment as Bulgaria, it's not so easy. So of course we made all this research and we described these outcomes, and it's very important. And I think that we added a lot of value with our project to the research environment of the remote patient monitoring systems, all the telemedicine approach, all the data approach for gathering data and biometrical data and how to use it, because we saw less developed regions. I mean, if we can say it like this, like Bulgaria, where the digital and the health literacy it's poor, and advanced regions as Austria when those parameters are higher. Of course, it depends also on the healthcare professionals, because the approach in Austria was a little bit different for discharge patients. In the case of the Public Hospital of Vienna, and yes, in our case was chronic patients, CVD and diabetes. In the ideal case, comorbidity patients, but not only post-discharge. And the idea of this, idea of this approach is to start with post-discharge patients, where there is a big gap of monitor them after dehospitalization, after discharging, when may occur a lot of incidents after some CVD interventions. And then, of course, to be applied for chronic disease patients as well, as was the case in Bulgaria. But it was quite difficult, but we know it, and we embraced this methodology.
Yeah, I think this is a very important point here, because it's not the same which group of patients you work with. Because in case of acute coronary syndrome, they have a very big trauma in their life. They almost died. Yeah, they are saved very, very quickly. So they live a normal life. Something happens. You are in a hospital, a lot of equipment around, people running, and so on. And then you are stabilized and you continue your life. And in 2-3 days, you are out on the street. That's what.
Hopefully not on the street.
Yeah.
At home.
Or, I mean, yeah. So they send you home. Yeah. And so this is what we saw in our case, that we had we could convince approximately 60% of eligible patients to start with us in this project. So maybe in a chronic patient where you have more time, there is not such a stress and so many so much new information, and they,
Restrictions.
yeah, till now you didn't have any pills to take, and now in a few hours they will tell you have to take this and this, and until
And stop smoking and drinking.
and yeah, and then till you leave, you cannot stop any of them. So it's so much information in 2-3 days that sometimes they didn't want. Okay,
It's
too much.
enough. It's
yeah,
too much
enough.
information
Too much
at once.
information. So for me, one thing, what lessons learned, this is important, that maybe it's better in the next phase of rehabilitation. I don't know what.
Definitely, this is actually what we. That's also a difference, because this is what we do. That we take the patients discharged from the ICU,
What's ICU?
intensive care unit. So patients who also had a big trauma, because an intensive care unit is something where you are really sick. So you have been discharged, and then the first months, 2 or 3 months, they have a lot of things to do, because they have to reorganize the life. And they also get some support, because they go back to the hospital again and again, and the GP is interested what happened, whatever. So in the first 2 months, 3 months, it's okay. But after I think there is a line after
When they
6
just
months
get used
or
to it.
6 or 3 months or 6 months, they stay alone. The system leaves them alone. This is probably the reason why we have such bad numbers of the survivors in the second part of the first year, because the control systems are just lacking. And
What's
probably
the influence of the family? Because my guess would be that the best device, is that my guess would be that men who are married have a higher chance to get through the whole process, because there is somebody to remind them, take a pills, etc., etc.
I have no idea.
We need to do a new research, Agus.
No, probably it's
research
true.
question.
Probably it's true.
It doesn't have to be wife,
Yeah,
it has
one
to be
of my
some
friend,
relatives that was living with somebody,
yeah.
because especially men, we tend
Simon,
to,
we can
forget a lot of
make
things.
new observation in the project.
Yes, we
that
have.
are going
Okay.
to
So
discuss
the
it.
but
pilot 5 will be that.
It's proved that if you live in a
Household.
healthy relationship, then you live longer.
Yeah.
So it's from this we know.
The impact of the family in a long-lasting disease and rehabilitation freeze is huge. So we have to count with the family in both ways. Actually, the family supports the sick patients, but also the family is also the one who has to be supported.
Yeah.
So actually, what we want to do with these devices is not just monitoring values and just collecting data, but we would like to give a helping hand to objectivize, to make feelings more objective. How do I sleep? Do I really sleep bad? If I change something, will it be better?
The advantage might be that also based on the data and based on the observation, we can find out that, for example, the patients have the sleeping apnea, etc., right?
Well, whether they have a sleeping apnea is not, probably this device is not good enough. But you can find out whether they have a bad sleep quality.
Mm-hmm.
And why do they have a bad quality of sleep or bad recovery? Then we can. This is another question what we have to dig in and find out. But we have a very objective way to see. Okay, something is wrong. Why are you tired every day? Is it because of the medication? The sleeping pills are just dosed in a bad way, or you just have a bad quality of sleep? So this is what we want to achieve with these devices. A little bit more, I always explain that if somebody goes to the GP every 6 months, there is one single shot or measurement of blood pressure and
Cholesterol.
weight and whatever. But I want to have a trajectory. I want to have a tendency, a trend. What I want to look at from the distance. I want to know what is between the two values. And this is what digital technology can provide us. Because this is the most important, actually.
And plus, one more thing is that at the beginning we tell them that we see if you provide any data. And also we can see if it really happens. So if there's no
So basically we can watch if the
measurements.
patient is following the rehabilitation that was prescribed to him, right?
Yes. And then you can call them and to ask what
intervene.
happened.
Yeah.
What happened? The battery went off, or is there some technical problem, or
Or you're
how
just
can we
ignoring the
help?
device.
Yeah, how can we help? So it should be a positive
Okay,
way of
so basically, if
communication.
I understand correctly, the path that this pilot is improving the care of the patient is that by the influence of the devices, we are forcing and motivating patients to continue with their rehabilitation based on the plan that doctors have created, right?
Yeah.
Basically, we want to improve results on the condition.
And what would be the measurable results that we are focused on?
Well, as feasibility study, we are measuring if we somehow improved the quality of life of this patient. Change of behavioral changes, start sporting, start measuring better, adhering to therapy as well, because we can put therapy like a measurement and to be observed by the physician. But in general, like a long-term perspective of this project is how to introduce and to make feasible and effective the remote patient monitoring of chronic patients, because one patient that had a cardiovascular incident, it's already a chronic one. So first we have observation of discharge patients after incident, but then we have this continuous care monitoring of those patients. And we are observing now cardiovascular and diabetes patients or comorbidities patients, but the idea is how this remote patient monitoring could serve for all chronic patients and how could be introduced. For example, this is very important in Bulgaria because last year we legally accepted the telemedicine in Bulgaria. And now for us it's very important how to organize it. And through this project, now we know what are the elements of the telemedicine, like remote patient monitoring, and what should we observe and what should we do with
By
all this
acceptance
flow.
of the telemedicine, you mean that you have you have found a path how to pay for the telemedicine?
Yes, everything. It's in a law now.
Okay.
So it's officially introduced in Bulgaria, but of course there is a lot of amendments that should be made as well.
Understood.
You asked about the obstacles for the patients.
Yes.
But let's
On
not
the
forget
obstacles for the providers as well. Yes.
Exactly,
Yeah.
because if you
And
you have to dedicate,
there are some countries. Yes.
you have to dedicate time, someone to teach, to educate the patient, to open the box, to charge the batteries,
Yes.
to prepare everything. So it needs extra energy, time, money. And so this is what we also wanted to see in the project, because if you see the obstacles of the provider side and you want to make a national program, you have to prepare for that, to see, okay, it takes 1 hour, 1.5, 2 hours for one extra hours for one patient.
But-
Does it fit in our system or not?
Yeah, but probably those devices do not need to be set up by doctors, right?
It depends.
It depends.
It
Yeah.
depends. So the setup time is not the most complicated one. I think the
Because
most
it's pre-programmed, I guess, right?
well, yeah, well,
not so much, but
it's not so
yeah.
easy because. But it's a. I think
That was
it's
one
a,
of the
it's-
challenge,
it's
right?
a- that was one of the biggest challenges.
You know,
But it's a project bias.
We can speak a lot of these challenges.
So
exactly.
don't open this.
So don't open this
Don't open
topic.
this topic. It's a project bias, I think. So, but on the other hand, if you give somebody a device and it measures data, and this patient just looks at the data, is he or she capable to decide alone, or you need a specialist to help them to decide based on the data what it means. So this is actually the biggest question. Is digital technology alone enough to improve quality of life, or I need digital technology combined with specialist time? Oh, well, in a repetitive basis, so every month or every second week or third week, it doesn't have to be a doctor, it can be a healthcare professional, an advanced nurse practitioner, but it's quality time. And I have to calculate it with the device together. Otherwise, the device itself doesn't make any sense. That's actually the research question what we raised at the beginning of the project, and this is how we build up the whole story. So we have actually 3 groups of patients. One group has normal care, like normal aftercare after a heart infarction. The other group has only the devices, and the third group has the possibility to manage an appointment with a healthcare professional every second week or once a month at least. And we will see what the results are at the end of the study.
What is the response of the patient for now?
Well, I only can tell it how it is in Austria.
Yeah.
The response of the patients is very good.
Because of the feeling that somebody is taking care
Yes,
of me?
I care. This is our slogan as well.
Yeah.
I care, so somebody cares on me. I'm important. And that's about everything.
In a way, can this be the game changer in the healthcare? Because now we can be monitored basically all the time if we want to. The question is if we want to.
If you are sick, yes, it's a game changer, in my opinion.
Or if you don't want to get sick. Because I think that, for example, as far as I know, there are quite a lot of people, who, based on their family amnesia, they tend to have cardiovascular disease. So can this whole project be in the future used also as the preventive care?
Well, it depends. Again, it's very important what Akush said, because the preventive care, it's the well-being part, and the reactive care, it's the hospitalization and taking actions when the problem it's already there. So yes, it could, but maybe then when we are talking about preventive care, I mean in the well-being part, we don't need a physician to take care of the patient, to take care of me. But when we are speaking about already a patient that had an incident that has a chronic
Disease?
condition, we have proven that it's dependable from a healthcare professional. So the remote patient monitoring, for example, in Bulgaria, it's better accepted when there is a physician.
Mm-hmm.
So not the technology itself supports the healthy behavior and the compliance. But yes, it could be introduced, and it's already in the well-being part. And we are all with smartwatches. Akush has 2 of them, different type
Right now?
for measurements.
I can
Yes,
see.
Of course.
You have 2.
yeah. Maybe he has somewhere hidden.
But the wedding ring is not smart yet, right?
Not anymore. I had it. I had
Wedding
a
ring,
smart ring,
but not
my-
the wedding one, right?
Yeah, though it was changed, but my wife told me a year later that I should actually
You
change
should
it
have
back
been
to
smarter earlier.
change it back to the
It's
wedding
nice,
ring.
nice.
or-
That's how they put it. She told me.
Yeah.
The first
That's how it's gonna be.
the first idea of device was this Oura ring that Akush is fan of them because
that was a good idea because you don't have to put it down. You don't have to. You can wear it all the time.
Yes.
You can go to the shower. You have to charge it once every second week or whatever, every week.
It was great.
It was a great idea. It did not work because, and it's also a project thing because we could not procure
procure
it
it.
in Bulgaria or in
No, no.
Romania or in
No, in
wherever.
Bulgaria, it wasn't the problem. It was you spoke with the provider.
Yeah,
and
it was
they-
some procurement
yeah.
story.
So at the beginning we were using also Oura ring, but we stopped because of
No. We just were in the planning phase.
Okay, in the planning phase.
In the planning phase.
Can we tell how many patients are involved currently throughout all of the countries? You're counting the names?
Yes,
you know all of them.
counting the numbers. 150 around.
Okay.
No,
From more
it
a
should
little
be
bit,
more.
200.
It should be more. So each
having
country,
a variable without a control group.
having
Without
a
control.
variable.
Just having a variable,
okay.
200
so
and
as
300 with the control groups
yes,
around.
yes, as Akush mentioned, we have three cohorts of patients, three groups. The one is the control group that we are observing just the behavior of the conventional care and patient pathway. There are 30 patients. Then we have 30 patients with devices and clinical support. And the third one is 30 patients only with devices without clinical support. So each country has 90 patients for onboarding, observing, and researching.
So the plan was 360, but I think
In 7 countries.
in 4 countries.
In four countries. So
But
it's Austria,
Austria, Bulgaria,
Bulgaria,
Romania, and Hungary.
Hungary. Okay.
So we are just moving around 300 because of inclusion criteria, problems,
Got it.
whatever, retention.
Peter, what might be the future outcomes of this whole research and the project?
Future outcomes.
Yes. Or the outcomes that you are expecting at the end of, I think the project is rolling till June 2026.
Yeah, I think we have to find the place where it is really helpful within the healthcare system. So that's what we were talking about a bit earlier as well, because we as providers have to learn what is it good for, and even the patients should learn, and plus we have to convince the finance ministry to pay for these kind of services.
It doesn't have to be ministry.
Anyway, someone. Yeah.
It's always taxpayers, I know.
Yes. And there's also another phase of devices which Akush has mentioned a bit, that his wife told him not to wear it anymore. So there's I don't know if you know the word healthization. When someone is, wears many things and tries to eat as healthy as possible. So we have to also warn our patients to measure things, over using these technologies, because that could put them under stress. And what Akush also mentioned earlier, they have a result which might be
Temporary.
not valid as well, because some things.
And
The
you have to
circumstances
put it
were
in a
not good.
context.
Yes.
And they cannot do it.
And in the middle of the night, he measures, I don't know, high blood pressure. He becomes stressful,
Freaked out.
and it's
Call the ambulance.
Call the ambulance, or whatever.
The pressure goes upper and upper.
Upper, and then so we have to be very careful with that as well. So I think that's what, as I started my sentence, we have to find the proper place for
And the balance,
such
because there is
balance,
also a threat that patients have a tendency to overuse the systems when they can, and when they see that my blood pressure is a little bit higher than it should be, they might have a tendency to visit GPs or even specialists.
Yeah. Plus, there are so many products from different countries which are not validated at all, and so there's another danger there, I think.
I think there is a very important point. Everybody, but you mentioned everybody has some kind of wearables, smartwatch, smartphone. So we are actually continuously collecting data right now as well. So the question is not whether we should buy or somebody should buy for our patients wearables or not. It will not be a question in 1, 2, 3 years.
Mm-hmm.
The
Because the
question
patients
is,
are already
they
buying
already
it.
have it.
Yeah.
The question is, who can use this data? There is also another question: who belongs this data to?
Yeah.
So who is the data owner?
It's based on the agreement we
It's
are
based on
signing
different-
every day without ever
Yeah.
reading the agreement.
Yes, but who can use this data? Should it be the big tech company,
They're already
or
doing
should
it.
it be the doctor?
Or both.
Or both? Or yes, if
Or the third parties.
well, anyway, but we should, as medical suppliers, doctors, healthcare professionals, should use this data. Therefore, the quality of the data should be actually regulated, at least in the European Union, that if devices provide medical data, they should be regulated that it's high quality. Then we could use the everyday variables, what everybody has, and use it as a normal way for our decision making. That is actually the future, in my opinion. But it can also go wrong, and insurance companies and big techs use the data, and the medical providers will not have anything out of it. So this is actually right now a decision time. Who has the possibility to
Is it still
get-
possible to decide, or it was already decided?
I think it's still possible to decide. It depends on the governments, what they want to do with
But the governments on the local or European level?
Both.
country government.
Country and European.
Country and European as well.
But it's a very interesting topic, because in medicine, every data belongs to the patient. So
In medicine.
in our everyday work,
Mhm.
whatever a lab test or a blood pressure
Yeah.
measurement, the data is the patient's.
Yeah.
He can say you can use it or not, right?
It's,
But
it's
it's
another
still-
problem of
But,
data sharing
here-
between
yeah, but
patient,
here-
providers, and
No, it's still
healthcare.
a fact. It's still a fact. The problem is that you're giving a consent when you're using, wearables.
Yeah.
Yeah.
If you don't want to share your data, you can. You
can decline and not use a wearable because it's unusable without it.
It's unusable.
Yes,
at
it's
that point.
unusable.
That's
at that
it.
point.
It's just
So
expensive watch.
You're a
Yeah.
little bit forced, to say yes.
But
Yeah,
it's
not
a
forced.
governmental
You don't have
question.
to buy it.
Yeah, but it's a governmental question that I want to have access to this data as a government, to use it for my patients, to use it for my citizens' sake. But it's also
again.
And
I'm not
what would
sure.
be the threat? Because I would say that, let's say, I'm more afraid of governments, any
but
government,
you are
than
not
tech companies.
Yes, but you are
More
more
of
afraid
the
of government than tech company. I don't know. I'm afraid both, but
Yeah.
It's a good tactic.
But you know that the potential is so big, because now using all these wearables, doesn't matter validated or not, we're taking very, very vital parameters that could be correlated with other data, genetic data, genomic, a lot of data, and make precision medicine, predictive medicine, very important things for the medicine. Of course, if they're for the medicine and for the healthcare, they should be validated, certified devices, medical grade devices. Also, the data should, as Akush mentioned, normalized. It's very important to have this layer, unified layer for this data, but the potential is huge. It's indeed very huge to take so much data. For example, we have a company that it's gathering ECG without
What's ECG?
it's
Electrocardiography.
electrocardiography. And the parameters correlating different parameters, not with blood pressure on the arm, but on the chest. And it's possible because it's correlating different parameters. And it's a huge potential for the medicine to taking new vital parameters, new biomarkers, digital biomarkers, and see how the human body and the healthcare, what is the dynamic there. So it's important, but let's hear the physicians.
No, but at the end of that's true. So I think the potential is huge. In preventive medicine, I think it's probably much bigger than in the aftercare, because, as you said, that it's possible to prevent things before you are facing a chronic disease or a problem. And it is actually preventive medicine as an interplay of a lot of factors, but it is very complicated to do that with restrictions, because you have to
But
analyze
they're calling for regulations.
We have to regulate how to deal the data, but you need the data. You need the data, actually. But there must be a very strict framework. Who can access the data? Who can see what is anonymized, what is not anonymized? So, but we need actually the data of these devices.
Should the health insurance companies use the data?
No, I think the health insurance companies. It's a difficult question.
Yeah, that's
In
the
Europe,
reason why I asked
we are
it.
actually in Hungary in a safer situation. But even if you go in a country where your health insurance can be immediately cancelled or revoked if they analyze your data and say,
but
okay,
you create a bias.
Yes, but on the other side, in Hungary, I believe Austria, Slovakia, and maybe Bulgaria, the health insurance company cannot cancel your contract, and it would be, from my perspective, it would be beneficial for my health insurance company to see those data, because they have more means of contacting me and sending me to my GP, sending to cardiologists, sending to
other way around,
endocrinologists, etc., etc.
If you can use the data, if you live a healthy life, you can prove with these devices, and probably you can pay less. It is like
in those countries, it's flat. You're paying based on your income.
But that's the reason. It's always the same. But I think the health insurance company is not the best. The best way. The medical providers are the most
agree,
important.
Because if you want a health plan, personalized health plan, it's not the insurance company that should create it. It for you. It is the medical professional.
That's why the tech companies are not the best, because if you stop paying, your data are lost. You cannot gain them. Get them, right? While in a healthcare service, you have to keep the data for at least 30 years.
Yeah, you can regulate it.
Yeah. So, and if we talk about prevention, then there it's very important to see continuous data, to see the trends. And then even I could imagine an automatic system when it would say, now you are in danger from now on. Your weight has gained, your blood pressure has reached a certain level, etc. And then you would have a message on your phone. It's too late.
Yes, turn it a little bit around. I think
sound like Terminator.
I think that readmission rates in a hospital is a huge problem in different countries, depending on the health insurance system. But actually, in most of the countries, nobody wants to have back the patients because it's not good.
Well, it depends.
It depends, but anyway, you can use these devices together with a predictive model, which is an early warning system that something is happening, and just to do and not just analyzing the data, but use AI to analyze the data, what you or I or any of the doctors would not see, in the continuous level. But you can use the AI technology to predict that there is a problem, make steps that the patient is not deteriorating early, not deteriorating and coming back to the hospital, which costs a lot of money. So I think that's why it's important to have this data for the healthcare professional.
I've seen such a system in Norway, and for a special patient group, they had, I think, 70% less emergency situations. 70%, which is extremely a lot.
At the end, this is the last question because we're running out of time. Can all of those devices at the beginning, there is investigation. You need to invest towards purchasing it, towards education, etc., etc. But is it also the way how to reduce the cost of the cure of the treatment of the patients from the long perspective?
Thanks to this project.
Yes.
Yes, of course, it's already done.
Maybe
it's
already done.
It's a bit early to say.
We succeeded.
We succeeded.
We hope.
The hospitalization is the most expensive type of clinical service that you can have. So if you reduce the hospitalization of one patient, you already made this cost effectiveness model that you need. And this, for example, in Bulgaria is our goal somehow. In Bulgaria, we do not take care of the health, because that's why the system is called healthcare, because you need to take care of the health, but we are treating diseases. So, and this is a very big problem. So we have over-hospitalization in Bulgaria, especially in cardiovascular domain. And this is a big problem, and it's very expensive. They're equal to oncology hospitalizations, or even nothing equal. They're more, far more. But if you can reduce through earning alert system, warning system, as Akush mentioned, as continuous medical support and care and monitoring, if you can reduce for a patient, one patient, 2 or 3 times the hospitalization during the year, this is a lot of savings that we could make on a government level.
I'm pretty sure that we will follow up with this podcast as well, but we are coming to the end, so thank you. Mira Ganova, Ákos Tibódi, and Peter Weyer. My name is Simon Eszeniak, and I will be your host throughout all of the podcast of Digi4Care. Thank you.